A second. Yes, they're on now.
Lovely. Thank you very much. Okay, well, firstly, thank you very much for the invitation to speak this morning. Caroline gave me that invitation and has sort of given me a brief to try and lay out a little bit about what interventional radiology is about for the trauma team, particularly perhaps more for the network and understanding what is on offer and how it might fit into your services. So I've laid this out as on the slide really, trying to give you a feel for what we do, how we can fit in with you, the sort of things that you need to think about in referring to IR services alongside all the other inpatient acute services that we work with. And I thought I might illustrate that towards the end with a few cases that I've done myself in the last year or so. So I hope that gives you a feel for what we're up for here. The trouble we have in interventional radiology really is that lots of people don't really understand what we do, and we've got to do a bit of education to help you along with that. We are really a surgical speciality, although we sit in a different college, and you could argue that what we do is pinhole surgery, so another step on from laparoscopic surgery. We do everything down a very small, minimally invasive hole. Now, this diagram I hope just gives you a feel for it, that everything from the neck upwards really is the province of interventional neuroradiologists. So experts in aneurysms in the brain, vascular malformations, just cerebral imaging in general. And they tend to have good relationships with neurology, stroke teams and neurosurgeons. Once you get below the neck, this is really what I do. This is both vascular and non-vascular in nature. And the sorts of specialities that I work with are as listed really, and trauma is very, very much part of that. Perhaps in volume numbers of patient terms, not that great, but all of the other specialities fit together with trauma, don't they? So patients come in with traumatized kidneys and bones and lungs and livers and everything else. So we do have reciprocal relationships with those specialities. The heart is something we don't get involved with at all, and when it comes to minimally invasive approaches, cardiologists are completely in charge there, but the aorta is often shared depending on the precise nature of service setups in each individual hospital. There can be vascular surgeons completely running that, it can be a joint thing, or interventional radiology doing stent grafting in the aorta. And of course, once you're into the thoracic aorta, thoracic surgery, cardiothoracics get involved there too. So you can see the number of relationships that we have in order to deliver our care and our services. So what is the role for IR in trauma? Well, essentially it relates to bleeding, as you might not be surprised to hear. And the way I try and keep it really simple is I think you've either got a bleeding problem due to trauma because of sort of wall integrity in a large vessel, or alternatively you've got active bleeding from a particular arterial focus. And those two things give rise to a different treatment modality. So for the first of those, we'd use a stent graft, literally to repair from the inside a big artery. Whereas if there's a little bleed or some other bleeding coming from a more particular focus, we're looking to embolize it. And those are the two major treatment modalities in our armamentarium to help you. CT is absolutely vital in trauma for us. It's the key aspect for diagnosis. It also helps us sort out the vascular anatomy. How do you get to the problem is vital for what we need to know and do. And of course, then it helps determine the management. Where is the bleeding? How big is the bleeding? What's the likely site of bleeding? Should that be surgical? Should it be something else? So CT absolutely is core to this. And the one point I would make, lots of hospitals use a particular trauma protocol. It doesn't actually work brilliantly for us because you tend to get very confused pictures in terms of establishing the nature of bleeding, in fact. And for us, we really want to know what the situation is before contrast medium in a CT scan and after it. So there are some issues that we could perhaps talk about that. I think one of the key things for lots of you working in trauma hospitals and trauma teams is to think about how you would prepare a patient if you're going to refer them towards an IR service. And this is perhaps a slight bugbear of mine. We shouldn't be considered as the poor relation of surgery or theatre. The patient is the patient, and they've got a particular physiological problem, and it's just a question of treating them equally to make sure that you can deliver the highest possible quality care. I think it's resuscitation, isn't it? You've got to get on top of these people quickly if they're bleeding, and make sure they're going to the right place to get the definitive hemorrhage control that they need. My own observation and experience, we need anaesthetists early, and discussions early, and planning early. It's all about that. And this is my personal bugbear, that the whole concept of cardiovascular stability people feel reassured by it. When you've got CT confirming good going hemorrhage in trauma, worry. Those patients need definitive treatment. They need it quickly, whether their blood pressure is stable now or not. Particularly in young patients, they fall off their perch quickly, and you're much better off getting to a definitive place of care and sorting those patients out. We've had a lot of discussion about these issues recently in my own trust in UHCW, and there's an argument about whether patients should be induced in theatre for anaesthesia or back in ED, and we could come on to a discussion about a hybrid theatre and how you deliver the sort of care I'm going to show you. And there's an argument to actually induce the patient in the emergency department, because that would help you decide where you might travel after that. And we could perhaps come and discuss some of the issues around that later on. I think one of the other key things is, as you're thinking about these patients, think about them going to theatre essentially, and they need blood products and all the other things that go along with that. Warmers, fluid, all of the stuff that you would routinely think of for going to a theatre environment. The thing I think is difficult to appreciate in what we do is, if you haven't seen it, it's difficult to sort of conceptualize it. We can be pretty quick. If you sterilise the groin, which is usually the way we go into an artery to get round the body, I know the cardiologists are very commonly going in the wrist now. That provides another level of complexity for us, and it's not the quickest way or the shortest route to get to most problems. But if you sterilise the groin, puncture the artery, put a little sheath in, you can get the catheter up to major target vessels really quite quickly. For something straightforward in our terms, like getting into the splenic artery, you can be up there in 2 to 3 minutes from putting some anaesthetic in the groin. Clearly, I'm not claiming that for everything, and lots of other things are much more complicated, but you can get up and sort things out in major arteries really quite swiftly. You can start that treatment quickly once you're there and gain control without the physiological insult of an open surgical procedure. Now, that doesn't mean it's always the right thing to do. I'm not going to try and claim that, but this is the principle that is involved in our field. And in our experience, we often have to convince anaesthetists they do actually need to stay, because things can be so relatively quick and the patient perceived to be stable. But we've had a lot of discussion with our anaesthetists about how they shouldn't be annoyed by that. It really is an element of proving that what you've done is the right thing to have done, and you've gained control in potentially unstable situations really quickly, and that should be the outcome one is actually desiring, rather than thinking is a waste of resources or a bit of a problem. So rather than me just tell you what I think, there is a little bit of thought behind this. Here is the most recent document from my own college, the Royal College of Radiologists, relating to standards and practice for guidance in trauma care from the imaging side of life. There's lots of things in there about diagnostic imaging, but I've just pulled out a couple of the standards that have been published there to let you know about them. So standard 14 in that document makes the point that interventional radiology facilities should ideally be co-located with the emergency department. Now, that is expensive and significant logistic sort out needed in lots of hospitals, but that is the aspiration, so that these patients can be treated quickly. Standard 15 in that document, it makes the point that angiographic facilities in major trauma centres should be a safe environment and of theatre standard. So the idea isn't that any old radiologist has a quick go. This has got to be high quality and properly thought through. Standard 17, and this is quite difficult for everybody to meet, certainly ourselves, the IR trauma team should be in place within 60 minutes of admission or 30 minutes of referral. And very often we are mobilising radiographers and specialist nursing staff from home, and everybody having to arrive to start a case out of hours. So that can be a bit of a challenge for us. In hours is a different problem as to what your elective work or your routine work that's going on at the time might be. What about the role of interventional radiology in this severely injured patient? Well, as I've sort of alluded, it's stopping hemorrhage as soon as possible, and with ideally the minimal interference to patients and their already damaged physiology from the traumatic insult. You can think of what we do as a form of damage control surgery. So it's very similar to pressing on a bleeding point or packing things surgically. And as I've said already, CT really is the key to informing this decision-making process and helping us work out how or whether we can actually get a catheter to the problem. Now, evidence. This is perhaps an Achilles heel, but it's likely, and this is said in the document, that there will never be true level 1 evidence for endovascular techniques in trauma. However, they also make the point there are no significant contraindications to the use of interventional radiology to stop bleeding in major trauma. And if you look in the literature, there is a growing body of evidence from around the world, and North America is usually ahead in this sort of area and field, that level 2 or 3 evidence is there now for its safety, efficacy, and particularly speed and, in fact, cost effectiveness. And that relates to beds, ICU stay, overall patient stay in the hospital, recovery from major surgery. That's where your benefit is. However, it is high cost to start off with. What we do requires quite a lot of staffing, quite a lot of expensive equipment and disposable equipment. And of course, you need cover. And that's my big headache running the service at UHCW with not nearly enough people. But that can, as I've alluded, also give you a cost saving when you compare that to some of the other alternative surgical situations, treatments and length of stay. The decision whether a patient with bleeding has endovascular care like my colleagues and I can provide, or open surgery, or indeed a combination of the two, one after the other or at the same time, that is difficult to give you a total feel for. The key is about communication, and you really need the trauma team leader to have thought about this, pull people in early to assess the CT, assess the patient, and pull everybody together with a clear plan about what you're going to do, where you're going to do it, and in what order. And those relationships between the different specialities are absolutely key in delivering optimal care. Those decisions, really should be made quickly, and it's why different teams and different hospitals should have thought about this well in advance and have clarity about how you can turn this sort of care and service on quickly. And I think it's all about communication. That tends to be right at the top of the list of how to make this work. Just to give you a feel for what we can do, this is the appendix I've just copied straight from that Royal College of Radiology guidance document I've referred to. So if you take something relatively straightforward like the spleen, here we are. What they're talking about here is the sort of non-operative management, interventional radiology you could do, or some sort of damage control surgery in trauma of these various different organs. And you can see that there are roles for all three components, and you can all imagine, I'm sure, patients that you've admitted or looked after where there might have been doubt or where it was clearly going to be conservative management or otherwise. But essentially, there is a role for interventional radiology in all of those body areas and systems, and it's just a question of trying to work out, with optimal communication and understanding of all the specialties, how best to deliver that. I can't sort of give you a precise algorithm because each situation and each patient is rather different. Now, what about interventional radiology versus surgery in reality? This isn't a sort of black and white situation, and nor are we trying to say that nobody should have an operation. Clearly, there is a role for open surgery, and there always will be. I think much of this depends on what you've got in each individual trust, what sort of services you're running, and what sort of time you can get patients into definitive places of care, how your logistics are set up. And again, this is, if you're going to try and think about getting patients to an IR service, it's all about trying to avoid the physiological insult and additional trauma of doing an open procedure. And of course, that could be a very large thing if you open the chest and the abdomen. It could be a smaller thing if it's just a pelvic injury or so on. So it's all very dependent on the precise situation. So I hope that gives you just a quick run through of the basics of what we can do. I thought I might just show you some patients I've treated recently, just to give you a feel for this, and maybe that might generate questions or thoughts later on. Caroline asked me to show you stuff that might have come from outside of UHCW, which is where we might start. Here's the first case, which was just over a year ago. This related to an 18-year-old man. I think this was a drugs issue in Leamington Spa. He had been stabbed in the chest and the abdomen, and there was actually a murder at that event. He got up to UHCW and had a CT just after midday, and that showed the following things I've written down there. So within 20 minutes, there was discussion going on with the emergency department consultants, and we were involved. Here are a couple of pictures from that imaging. This is the key image here, this sort of sagittal reconstruction, and I hope you might see what's happened here. When the patient breathed in and had a sword thrust completely through them from the back to the front, you can see some locules of gas here in the subcutaneous fat posteriorly, and you can see how the blade has passed straight through the liver and out the far side. The patient didn't have the blade still in them, that had been removed, but there was an active bleeding point here more anteriorly, which on the axial images, the sort of view you would more normally look at, you can see was actively bleeding. There's already a rim of blood outside the liver here. So how do you treat that? Well, from an IR point of view, this is what we did. These sort of pictures you're going to see in my talk here, what you're looking at, just to orientate you, is this is a catheter up from the groin into the celiac axis. So that is the splenic artery. The spleen is beginning to opacify out here with X-ray contrast. Here's common hepatic, and this is branches down toward the pancreas. Now, what you can immediately see if you have your eyes tuned in is a little bit of bleeding, which is correlating with that CT finding out here in the liver parenchyma. And once you can progress up the common hepatic artery, you can get a really good view of this ongoing arterial bleeding, and with some judicious care place a microcoil into that selective vessel to stop the hemorrhage. However, because the blade had clearly gone through the patient from back to front, you do need to look elsewhere. So this is now in the same maneuver into the intercostal vessels at various levels, just to check that those hadn't been sliced open, which they had not, and then check again in the liver. And in fact, when you go back in, you could see even more bleeding a bit further on. So at that point, a few more coils were placed, and you can see how angiographically you now have this area of paucity of small vessels, whereas the rest of the liver is being perfused, but the bleeding did settle down very nicely. As it happens, we were complicated in this procedure. He had some VT later on, and we weren't at all sure what was going on and thought it all might have been drug related. But he had his chest drain out a day or so later and was discharged into the care of the police. So what about outcome here? Well, we've avoided a laparotomy. I think if you'd had a laparotomy, you'd have had to have done either a right hepatectomy or pack the liver. He would have had to go to ITU, I suspect, and did not do that. He was actually discharged from hospital inside 4 days from what I would have thought everybody might think was a life-threatening injury, and surgery in that situation, has a number of issues with it, I would suggest. He does remain in prison as far as I understand it. So that's the first case. Here's another one. This was from August last year. Everyone's been very down, haven't they, with the lockdown? And I think there were a number of presentations to our trust with people who were suicidal. And this lady was in such a situation. She had fallen from 3 stories, had a GCS of only 3, and was very unstable hemodynamically, had a CT scan. A number of injuries were identified. Here you can see a big long list of them. And the main issue was, in fact, her kidney. I'll show you why in just a moment. But there were a number of fractures, there's shock bowel, there's all sorts of lacerations to the viscera. So, difficult perhaps to see all these in order, but this is more superiorly. So you see liver, the low part of the liver. And if you notice, there's well opacified left kidney in all these slices, but the right kidney, you just don't see it. It's not being opacified. There were a number of other injuries which I'm not deliberately showing you here, but the issue that we went for was the kidney. So once again, here I am with my catheter up into the left kidney, which shows you what a normal renogram looks like. Once you get to the other side, you could see there was an abrupt cut-off here in the right renal artery, and we knew from the CT that that was bleeding. So you don't see it initially, but if I just poke a little bit further, you come straight out into the retroperitoneum here. And so actually that was a transection of the right renal artery, which is why the right kidney was being devascularized on those CT images. Once we sorted that out, what you're looking at here is from each groin I've got a catheter. So this one with the curly tip is called a pigtail catheter for fairly obvious reasons. And that contrast is being injected in the aorta, so you're now seeing all sorts of different arteries. But the other catheter here is delivering the treatment into the right renal artery, and what you can see there is I've placed a number of coils here into the retroperitoneum, and then back there's a little plug device between these two markers here into that renal artery stump, and that stopped the bleeding. Perhaps for discussion later on, this was a bit of a logistic challenge. The patient, by the time I got hold of them, was already in theatre, and we don't have a hybrid theatre in Coventry, which is a bit of a problem. So all the surgeons involved had discussed it with me, and we were saying, yes, let's go and get this patient downstairs. We had to actually hoik them out of theatre to get them back down to the radiology department and do what was necessary. And that added, another 40-45 minutes onto the delivery of this procedure. So how you get people into the right place at the right time is really, really key. How did this patient do? Well, we stopped the abdominal bleeding from those coils and the plug. She didn't need a laparotomy. She did have other injuries, as I alluded. She had diffuse axonal injury and fractures in the spine. Those were treated conservatively. Her chest tissues and all the fractures elsewhere were treated conservatively. And her liver and splenic lacerations were similarly watched and didn't need any intervention. She was discharged to a rehab unit and has some follow-up due in neurosurgery, and that's all been delayed by pandemic issues. Okay, how are we doing for time? Maybe another one or two of these. Okay, there's a 25-year-old we had from Northampton, so I know a lot of people on the call are from Northampton. This was a road traffic accident back in September, and I know there was another person who died in the accident in the same car, I believe. So this patient was induced at the scene and was very tachycardic and had some reduced air entry at the left base and got a trauma CT on arrival. Lots of injuries here. So there was another high-grade injury to a kidney with a left renal artery dissection, which you'll see in a minute is what we went to treat. There's possibly also an aortic intimal injury from this deceleration trauma that was experienced, and our radiologist had advised speaking to our teams in the IR. There was a big retroperitoneal hemorrhage and some rib fractures, and also some fractures involving the spine. So here are the CT images from this patient. And again, if you just take a moment to have a careful look through and see if this makes any sense. I think again you can see that there's contrast in the right kidney. Here you are. But the left kidney, look, has contrast opacification in its interpolar region or more towards the lower pole, whereas in this area there's no contrast again going into it. Another little injury in the lateral cortex on the right side. Now on this occasion, this wasn't a transection, this was a dissection. So here you can see the catheter coming up and into the left renal artery ostium. And this marked change in calibre here was the reason for that hypoperfusion in the kidney. Now you can treat this with a little stent. So you can see how we've managed to open that artery back up again and improve the perfusion back to the kidney. And that's what it looked like afterwards when you inject contrast up in the aorta. So we've got the right kidney, the right renal artery is here, and the left renal artery is there. And in fact, this patient has an anatomical variant. There was actually a dual renal artery, which is why there was contrast in the lower pole on the CT. But this is our follow-up CT, which I reported only about a month ago. And you can see that stent sitting there, and it's well opacified kidney that's been salvaged from that single manoeuvre. And just as an aside, this was her creatinine, which I've dug off the hospital system. You can see when she presented, she had quite a rise for a young fit patient, which then improved after we did that revascularization. She's seen by my vascular surgical colleagues for clinical follow-up and is absolutely well, and her renal function is normal. So she was discharged on day 11. She had to be started on some antiplatelet agents, which is our usual practice if you're putting in stents or stent grafts, so that has to be borne in mind just to make you aware. She was mobilizing with a walking aid. She had some pain control only on oral medication, and as I said, she's been seen by my vascular surgeons and she is well. How are we doing for time?
We're absolutely fine. We've got plenty of time.
Plenty of time. Shall I show you this one then, and we might call it a day on cases. This is a patient who presented to us from Warwick, and he was 59 and fell downstairs. He had a head injury and some C-spine tenderness. Took a while to get to us, and we can talk about transfers perhaps and communication from more peripheral hospitals to the larger centres. But there was a CT done in Warwick which showed a big hematoma, and I'll show you that in just a moment. It was in the subcutaneous tissues of the right lateral flank, extending over the iliac crest. And this patient had fallen downstairs with a comminuted fracture of the olecranon and an elbow dislocation, very hypotensive. Here's that CT from Warwick. So you can see the difference in the subcutaneous fat, which is nice and black on this side, but this side is not. And there's actually a little contrast blush here, lying lateral to the iliac blades. This is just a lower view showing you exactly the same, complete difference in the two sides. Now, this took a long time. So by the time this patient was seen in Coventry, it was 9 o'clock at night, but the anaesthetists were there. So I couldn't actually do anything until the patient was in our trust and had been sorted out a bit. A long period of resuscitation here and remained hypotensive. And part of the trouble was this patient was a particular high-dose antiplatelet agent, which I wasn't actually very familiar with, but was difficult for them to reverse with hematological manipulations. And we didn't even get to the IR suite till late at night, really. This was done under GA. So on this occasion, I've got from the left groin over, this is the aorta here, into the right side. And if you haven't seen these before, it might look a bit strange, but basically this is a very, very hypotensive and vasoconstricted patient. The arteries don't normally look like this. So you can tell angiographically, from our point of view, just how shut down a patient is.
Sorry, James, we
What
can't
have they done?
yet. Ah, now we can. Apologies.
So, okay. So what I've done now is through this main tube, we use a guiding tube and then a microcatheter to work our way around all the branches to try and find out where that bleed is. So this is actually the inferior epigastric artery up the front of the anterior abdominal wall. And then I'm looking here at what I thought was the culprit and turned out to be. This is the lateral circumflex iliac, which is a branch just above the common femoral. And when you get up inside there, you can see this blush, and these wiggly arterioles heading out into muscle. I've already begun to put little coils in here, and then many more coils, and because of this antiplatelet agent the patient was on, it kept bleeding, so I had to keep going until we had taken out all of that branch. But immediately on doing that, you can see how the arteries begin to open up, and that vasoconstriction release. So he had another CT at day 3, which showed no further bleeding, and he had his orthopedic surgery to the elbow fracture somewhat after that, and at day 6 went home. He was discharged with physiotherapy, and all that was arranged through his originating hospital. So I think in this one we did avoid some open surgery for hemorrhage control, and I think he ended up with a much more controlled orthopedic procedure in the calm light of day, which I think was the benefit we were able to offer to this particular patient. I'm just going to skip through this because I think we could probably draw this together because I'm showing you much the same, really. Caroline asked me just to mention, what about innovations and thoughts for the future? Well, You know, should a major trauma hospital have its IR suite in the emergency department? Very much in North America, they do this. You can get a patient into the emergency department through a CT machine, and then very often into the next room, or even off that machine into an angio suite in the same facility. How we get there in the UK is a matter for planning and thinking, because I don't think many hospitals in this country have got that at the moment. There are some. Hybrid theatre. So what is a hybrid theatre? For those who perhaps haven't thought about this, a hybrid theatre is essentially a big, larger than normal theatre spec space used for both open and endovascular procedures. So one might have this image intensifier generating the pictures that I've shown you in those cases, that's maybe at one side of the room or can be swung in, and an interventional radiologist can do the first bit of the care and then move the machine out, and open surgeons move on. Or even you could have different sorts of specialty surgeons involved with the patient's care, so not only orthopedics but general surgery, neurosurgery, all these other things all together in one space. It's a big topic of debate in the UK as to whether that should be an absolute requirement in a major trauma centre. As I understand it at the moment, it's an aspiration rather than a major requirement. But my personal opinion is that we would be much better offering patients their care in a hybrid situation for these sort of specialised episodes of care that are required. We could also potentially talk about aortic occlusion balloons and whether RIBOA, which some of you may have heard of, as a way of sustaining people's blood pressure emergently, is useful in the emergency department, and whether actually, if you have to transfer a patient for interventional radiology and we can't gain control, whether RIBOA has a use then in order to maintain blood pressure on the way towards an open surgical procedure. So I'd have thought those are the things that one needs to think about in terms of IR and its relationship to trauma services. So here's my email address if anybody wants to contact me directly. Very happy to take any questions and think about anything for a further discussion.
Thank you, James. There are some questions coming through the chat, quite a few of them. The first one would be, are there any absolute contraindications to imaging, to radiological intervention in trauma? Is there any case that you wouldn't touch?
Okay, I think the basic answer to that is it depends on stability of the patient. If the patient is clearly grossly unstable and will not have enough time to make it to a definitive place of IR care, we shouldn't be doing that. If you are lucky enough to have a hybrid theatre where the patient clearly goes from the emergency department to a hybrid and you can do any form of surgery, including endovascular, you should go and do that. And then it becomes a matter of the management and communication in theatre as to what's going to get done and in what order. But in our situation, where you still have a binary choice as to where the patient is going to go, they're either coming to our theatre spec spaces but happen to be in radiology because that's our facility, or they're going to theatre. There is stuff that I think is not appropriate for us to take, and it's usually cardiovascular instability and peri-mortem type stuff. I have to say, I know the surgeons are often fearful of this. What happens if you go to radiology and the patient becomes unstable and needs to go to theatre? In my experience and all that of my colleagues, we've never actually ended up in that situation because we end up getting control. We've never even had to blow up an occlusion balloon to transfer the patient out of radiology into somewhere else. So I'm not saying that would never happen. Of course it could. But in our experience, we've been running the IR on-call service in Coventry now for 10 years. It just hasn't happened. And I suspect that part of that is because you're forced to decide where this patient is going to go. Yeah. And so very unstable stuff hasn't come to us.
Is there anything similar to the golden hour in trauma in interventional radiology? Do you have a time frame beyond which you would not activate, or you wouldn't go in from the trauma or from the patient becoming injured?
Okay, I think the answer to that is in two parts really. One is the physiology applies to the patient as it does for anything else. So there is a golden hour, definitely. So the sooner the better is the basic answer to that. Once one is down the track, I think it all comes down to what's the right thing for the patient now, and I'm not trying to be too fluffy. It's literally a case of what can be achieved, and it's all about the discussion with the relevant systems, surgical specialities. So in those cases I've shown you, there were some kidneys. We need to discuss that with the urologist. What happens if we can't get in there? Would you take this kidney out? Would you do a partial nephrectomy? Would we just tie off the renal artery? Those discussions need to be had before it's agreed what we're going to do, and we need a plan B. So if we're going for plan A, and we know that we're trying to embolize that or stent graft that, if it's not working out or we're not happy with it, where do we go next? And that is the key, I think. So I'm less worried about the time after the injury. I'm more worried about that. What are we trying to get to? What are we trying to achieve? If the neurological function is going off because there's a brain injury, we're all concentrating on the spleen. There needs to be some all-over thought here, and I think that's where ED and the trauma team leader is key, to really think through the whole patient, because once it is sent to me as a splenic problem, we are going to be somewhat focused on that, and then rely on the anaesthetist to tell us about the body system physiology before we work out where they're going next. And there needs to be a point of contact to decide that.
So basically, leadership, like everywhere, is crucial.
Absolutely. Yeah.
Yeah. Are there any specific risks post-insertion of stents or embolization? Do you follow up your patients, or how does that go from that point of view? Because I'm sure that the vast majority of us would not know how to follow up those patients.
Well, that's a good question, because out of interest, we are officially a subspecialty in interventional radiology at the moment. It's a subspecialty of clinical radiology. However, the British Society of Interventional Radiology, which by the way represents about 440 of us in this country, we have voted to become a speciality. Now that's going to take some time, because although we have a curriculum and it's all written, it's going to have to go through the GMC, and that in itself is going to take some years, and COVID has put it all back. So sorry for the sort of side alley, but the point is that more and more of us are seeing patients in our own clinics and behaving like an independent speciality. So the answer to the question is, we should follow these patients up, we should see them on the wards, we should take clinical responsibility, but it is a speciality in progress from A to B. And I try and see as many of the people I treat as I possibly can, but very often, as you've seen in the examples I've shown you, there are multiple body systems, and quite who it is who's going to do the follow-up is usually the one, in my experience and observation, who's still got the ongoing clinical problem. So if it might be neurological, it tends to be them, because everybody else says, oh, the spleen's fixed, the legs are fine, your issue. That might need some wider thought. In terms of the specifics, as I've tried to lay out with some of those cases, if you put a stent in somebody, or a stent graft, so a stent graft is a covered stent, usually you do need to have them on antiplatelets, sometimes dual antiplatelets, depending on where it is, and that clearly has a risk benefit to it. Coils, don't worry about it at all. So most embolic products are needing nothing to follow them up. What we can end up doing is,
What's that?
I can think of a situation, perhaps, so say you refer a patient with a grade 4 laceration of the spleen, or a spleen that's falling apart. There are different ways you can embolize it, and without getting too technical, you tend to often put things right down the vascular bed into the parenchyma, and then coil at the front. That's different than just coiling at the front. Now, when you do it at both ends, you can infarct the spleen, and in so doing, there are sequelae from that. So you can get pain and so on. But the actual management of the embolic material itself should need no further medical input, really.
The next question for you, James, comes from Tom from Northampton, and I kind of relate to that, because we're both coming from trauma units. Do you have any kind of teleradiology facilities? Can you see CTs from home? Could you activate from for patients coming from outside the center and be ready on arrivals, things like that? Or you depend strictly on the activation from the trauma team from Coventry? Is there any way that the areas around you could refer or could early escalate the patients your way in order to improve those outcomes and minimize the surgery?
Okay, that's a very good and important question. The bottom lines. So yes, we do have access from home to UHCW imaging. So the imaging has to go to the UHCW portal for us to see it at home, is the basic answer. So I can see a Warwick scan or a Kettering scan or a Northampton scan if it's already in the UHCW system. And very often these cases are out of hours, so very often one has seen it at home and been on the phone to the relevant trauma team, ED people, anaesthetists and surgeons of the relevant specialities before deciding, and then you get in the car and come and do it. So directly, no, but through the UHCW portals and trauma service, yes.
Right, so you are activated sometimes before the patient actually arrives at the
yes.
Coventry. Right, I didn't know that.
Yeah.
And there's another question, quite interesting. If no hybrid facilities are available, should the patient just go to the regular theater, or if there's an assumed single point of hemorrhage, or should that judgment call be made as a joint team, or is that judgment call being made by the team leader in ED?
So if I'm understanding what you're saying is there's a single bleeding point.
Yeah.
I think the key aspect for us is, and for everybody to understand on the call, that the sort of imaging you can get in theatre without a formal hybrid theatre is too poor. So if you look at what's happening in vascular surgery around the UK and the world, quite rightly, people are trying to do endovascular aneurysm repair, so EVAR or TVAR in the chest, in a hybrid theatre environment. So the quality of the imaging is the same sort of thing we can produce in radiology, and it is key to being accurate, putting the stent in the right place, understanding the flow of blood, seeing what the branches are. At the moment, EVAR in Coventry is being done with a standard mobile intensifier wheeled into a standard theatre. Now that's okay for a standard infrarenal endovascular aneurysm repair, a standard EVAR. You can do it. But it's not comfortable, and as soon as you get anything complex, difficult or small vessel, you simply cannot see. So that's what I'm referring to about this binary decision for us in Coventry. You have to make a decision about what the management is and put the patient towards it, because once you're in theatre, essentially the imaging for anything complex or needing small vessel treatment is out of the picture. So you're committed surgically, and then you're packing or taking things out.
I think the next question you actually answered by all of this. The next question was, is there a use for EFAST in place of CT to activate, or do you always need a CT before you go in? I would say you've explained that already. I don't think
I simply won't deal with the referral without a CT. Let's keep it that simple.
I think that's fine. And there's another one. And this is the last one that we're going to take. Do you have an audit on patient satisfaction or experience post interventional radiology? Do patients feel that they benefit more than from classical surgery? I hope they do.
I'm very interested you asked that, because the chat in our department yesterday, when I said I was giving this talk, was, we'll be able to do an audit of this, that, and the other. And the absolute yes is obviously the answer. We should. The trouble is, like I referred to earlier, getting solid academic data around this area of practice is really difficult, because the traumatic injuries are all different, and the background in medical status of all the patients are different. So even in that small series I've shown you, there's a young fit man who's been stabbed through the liver, but he's otherwise fine apart from taking too much drugs, versus an old gentleman on complex antiplatelets who's fallen down the stairs. They're so heterogeneous, it's very difficult to pull out solid data. However, of course, we could look at very simple things, and I think meeting the standards in that document I've shown you is an obvious thing to try and do, and trying to make sure that your embolization or your stent grafting procedure was successful in some accessible way or not is obviously a simple audit one could do. So on the caveat that the numbers coming through of these that make it into an IR suite for something specific is relatively small. When I look back in order to prepare the talk, I think, I'm talking about myself doing 10 a year, that sort of thing, 10 to 12 a year, and I've got 5 colleagues. There's 6 of us. So, you know, it depends. Most of them are spleens. Most of them are bleeding spleens, but bleeding livers and things. The last time I had to do a I can't think of it must be 2 or 3 years since I had to do a TEVAR for a ruptured thoracic aorta. They come in runs of 2 or 3, and then you don't see one for ages. So you've got all of those things coming together, but a simple audit along the lines I've suggested is doable and should be done.
And if you don't mind, I would just put a question from myself, because there's something that you said that kind of triggered an idea. You said there are 440 roughly interventional radiologists throughout UK, and you said there's 6 of you in UCHW, which is quite a large number. I'll say. Is there, or would there be a role in the future in potentially stabilizing the patients in the small units before transferring them out? Because sometimes we waste valuable resources and valuable time by transferring via ambulance, and those transfers usually take about an hour, even more, depending on the situation. Is there a role in the future for, or a scope in the future for developing this sort of a service?
I think the basic answer to that is yes, in my view. Quite what the money and logistic support that's required and how that's managed is outside of my jurisdiction. But I'm imagining something like a very simple scenario, a bleeding spleen, say at your hospital, you've seen it, you're managing it conservatively, you're worried, the patient's in a ward, the blood pressure's all right, but the hemoglobin is drifting downwards. You do another CT at day 3, it's still oozing. I can imagine you think, let's get something definitive here. And perhaps, I don't know your service exactly, maybe that would either mean splenectomy at your site or transfer out something, I imagine.
Those are usually the options.
Yeah, I can imagine in that scenario, you getting on the phone to us and saying, look, here, CRCT, I have a look at it and go, yeah, we can embolize that. My issue then is beds. We have actually, as I referred to, in becoming a speciality, we do have day case beds in our department. I've got 7 beds that we admit people to under our own names, and that works very well for our elective work. We're yet to get to the position where I have admitting rights, or any of my colleagues do, to the main hospital to do something like that, but we will do it under a surgeon. So it would be under the general surgeons. So if you spoke to us and said, can you do this? And I'd be, yeah, that's absolutely fine. It just needs to be in a surgical bed. Here's the bed manager. Sort that out. We'd let them know that we're prepared to do it. You've then got that logistic.
Lovely.
But as far as I'm concerned, medically, that's absolutely fine.
So that's very doable.
Yeah, absolutely.
Lovely, James. Thank you ever so much for the talk. It was great to have you today. I think we're going to take a short break and reconvene all of us at 11 o'clock just to keep on the program. So you can grab a coffee, stretch your legs for a few minutes. I would suggest not to log out, just mute your microphones and put your cameras off. And yeah, we'll reconvene at 11 if everybody's all right with that.
Thanks, Andre.
Thank you.
Okay.